Hello and good evening, and welcome to Spine Time, your free webinar with our experts at Weill Cornell's Center for Comprehensive Spine Care. And tonight, we are going to be speaking on the topic of how small can it get? Innovations in minimally invasive spinal surgery. My name is Neel Mehta, and I'm Director of Pain Management here at Weill Cornell. And I'm joined today by our co-director and head of spine surgery, Dr. Roger Härtl, and Dr. Eric Elowitz. Dr. Roger Härtl is a professor of neurological surgery and director of the Weill Cornell Medicine Center for Comprehensive Spine Care. And Dr. Elowitz is the associate professor of clinical neurological surgery and an assistant attending in neurological surgery here at Weill Cornell. So with that, I'm going to turn it over to Dr. Härtl and Dr. Elowitz to walk us through the technology advances in spine treatment.
Well, thank you very much, Neel. Really, this is a great opportunity to talk about a lot of the advances that we have in spine treatment and show this slide. This is kind of the way spine surgery, spine treatment in general was years ago, sort of in the horse and buggy phase. But if we go to the next slide, we can see how things have really changed. And now we're really in the space age, so to speak. I think all of us at the Weill Cornell Comprehensive Spine Center have a conservative approach. We really try to avoid surgery in patients, and when at all possible, obviously we want to treat someone's symptoms, treat their pain, get them back to their normal life and their function. And we really have a great team to do that in terms of pain management, rehab, neurology, physical therapy, even psychology, and of course surgery. But in some cases, surgery is going to be needed. Patients who've tried other kind of treatments and are still having intractable pain. So in cases where surgery is needed, we really want to do, and our philosophy is to perform the least invasive surgery possible. Here at Weill Cornell, we really pride ourselves in our adherence, our interest in minimally invasive spine surgery. And I think that's a lot different than so many other centers that we see around the country, even around New York City. Some of the big differences compared to years ago, we have a much better understanding of the spine. Things like spinal alignment, how we stand, has a big influence on how much pain someone has. And of course, any kind of treatment, particularly surgery, can have an influence on our overall alignment and our posture. Imaging, when we evaluate a patient because they have a problem, they may have pain, we have very advanced imaging techniques, including MRI scans, or CT scan, X-ray equipment. So we know and can diagnose the problem. We really can't treat a problem until we know what the problem is. And certainly if surgery is being contemplated and considered, we want as much information as possible. So the days of exploratory surgery are well behind us. Plus, in terms of minimally invasive surgery, we have tremendous amount of technology in the operating room, as microscopes, computers, navigation, which is kind of like a computer in the operating room that guides what we do as surgeons. That makes the analogy to patients kind of like a GPS or Google Maps. So that when we're doing some of our surgeries, we're actually looking at a screen that will tell us where we are. And that's often based with some of the radiology equipment, such as CAT scans that we have in the operating room. And of course, newer technologies like endoscopy, endoscopes, and emerging technologies as well, including stem cells. Go to the next slide.
Yeah, Eric, I think you really kind of summarized the the philosophy behind minimally invasive surgery, and you can really only treat what you see, and that's where imaging, as you mentioned, becomes so important. And this is an example here on this slide, an MRI scan that shows that this patient has severe lumbar spinal stenosis. And then obviously you want to look at the patient, you want to make sure that the MRI scan fits with the patient's symptoms, because only then can you really make sure and guarantee that your surgical intervention is going to be successful. So we need the imaging, we need MRI scans, we need computer CT scans sometimes, and all these things really come together in then allowing us as surgeons to make intelligent and targeted decisions in terms of where surgery is really going to be helpful. If you go to the next slide, Neel, I'm just going to summarize a few of the advantages of minimally invasive surgery. This came not out of nothing. Minimally invasive surgery really evolved, obviously, over many years, and it's really based on an understanding of the anatomy, what's causing pain, what's causing the weakness, understanding really how all these things play together in causing the pain, in causing patient symptoms. But once you make the decision to perform an operation, in the majority of cases, it is really advantageous then to consider minimally invasive surgery, because there's less blood loss, the infection risk in patients is less, patients get back to normal activities earlier, they return to work earlier, and these are some of the main advantages, of course, of minimally invasive surgery. Now, one of the things that we started doing here is endoscopic surgery, and Eric can tell you on the next slide what that entails.
Yeah, the endoscope is a tube that has a lens that's connected to a camera, so that we can look at a screen and see a tremendous magnified view of where we're working. And this, in order to place the endoscope, we just have to make a very small incision, just about a quarter inch, compared to many surgeries that are done where it could be 2, 3, even 4-inch incision. And it's not only the incision, but it's what's happening to the muscle. Think about a gallbladder surgery. People who had gallbladder surgery, could be 20, 30 years ago, had to make a very big incision to go in, open everything up. And now virtually all gallbladder surgery is done with little tiny holes for the endoscope, like little key ports. And that's really the same with a spinal endoscopy. Obviously, not everything can be treated with an endoscope, and maybe not everything should be treated in a minimally invasive way, but it certainly is our philosophy to do this minimally invasive surgery really in every case that we can, and we want to really do the least invasive surgery for our patients to get them back active, functioning, comfortable really very quickly, minimizing the amount of blood loss, infection risk, as well as the recovery.
Let me ask you a question. I'm always wondering, because endoscopic surgery sometimes can be done in patients being essentially awake or sedated in the operating room, and I've always wondered, how safe that is, and if patients really want to be awake during their spine surgery. I'm always wondering that, but I know it is an option. What's your experience, and what's your recommendation if somebody asks you, should I do this under general anesthesia or under sedation?
I think you raised some very valid points. Because the incision is so small, because these surgeries are often so quick, sometimes 15 to 20 minutes, they can be done under local anesthesia with sedation for patients that are kind of sleepy during the procedure and not fully awake. But I have to say, most patients, when I speak to them about a surgery, they say, "Is this going to be general anesthesia?" And I say yes. And they say, "Oh, good, I really don't want to be awake for this." So I think some of it's a conversation that we have to have with the patient. But even if it is under general anesthesia, it's kind of a lighter general. There are certainly different levels, in a sense, of how long someone's under anesthesia, how much medication they're given. And still patients go home the same day within a matter of hours. So I'm not really convinced that it makes any kind of a tremendous difference one way or the other, and still patients are still up and moving and walking within 2 hours, and usually home within about 2 hours.
Well, I think this is pretty exciting. We've already seen some great slides and talks about the innovation in this space. I think I remember back to my days in medical school and doing a neurosurgery rotation and hearing about the birth of microdiscectomies out in a surgeon in Las Vegas. And if you guys know this story, you probably could elaborate more than I can, and how that really revolutionized spine surgery. Maybe you want to share that, or
the story, and I don't know how much truth there is to that.
it certainly makes for a good story either way.
The story is that a surgeon in Las Vegas decided to do as very small incisions on some of the Las Vegas showgirls so they could be back to work quickly without a scar. So he started to do surgery with small incisions. I'm not convinced. I've never evaluated the truth of that. Maybe a urban myth or a surgical myth, but there's no question that what we can do today is dramatically different. I have to say, like when I was in training for neurosurgery, and we're going back, number of years, in order to do a patient had a herniated disc, and we were doing a discectomy because they had a herniated disc with terrible sciatica. We had to make an 8-inch incision. And those patients were in the hospital for 7 nights. And I remember that because I, as a resident, round on them. And now we're doing these surgeries very often with a endoscope with a 1/4-inch incision, up and walking within 2 hours, and back to their normal life, often back to work within that time. So, we certainly have seen a dramatic improvement in our surgical techniques, and I think it's exciting to see where the field is leading to.
Yeah, that surgeon in Las Vegas was one of the first surgeons to use a microscope for spine surgery, and that's what allowed him to make those small incisions. And now we're seeing, as you mentioned, Eric, now the next step, maybe the endoscope. I can talk a little bit about if you let me look at the next slide. I can walk you a little bit through the evolution in terms of imaging in the operating room. Now, Eric talked about patients who have a microdiscectomy, so need a decompression, but some patients need a stabilization of fusion because they have instability, trauma, sometimes infection. And when we put in implants into the spine, we're always worried because obviously there's a risk. You got to make sure you don't touch a blood vessel, a nerve, because that can cause pain and other complications. So we use navigation as a GPS system. It's essentially a ways of the spine that shows you exactly, even though you can't look at it, but it shows you on the screen. You can see inside the spine exactly where you are and where you put these screws or implants or rods. And you can see that here on the slide indicated in red and blue. This is a patient where we do a minimally invasive fusion, and we put those screws through very, very small skin incisions into the spine. And so that's one of the technologies that we really spearheaded here at Cornell over the last 15 years, and that we use now routinely in patients who need a fusion. So whenever anybody needs a fusion where we put in screws or rods, we will always use navigation. And we have shown, and others have shown, that this makes surgery safer and more accurate. And it allows you, the question is how small can it get? It allows you to do a big operation through a relatively small incision. Now, the next step is what we've tried doing years ago and now do almost on a routine level. If you go to the next slide, Neel, is actually augmented reality. So now not only can we see inside, but we can actually look at the spine, we can look at the skin, or we can bring in the microscope and look at the area where we're operating, and we can see structures deep inside the spine, such as disc herniation, cysts, a tumor, or just the bony anatomy if necessary. So that also gives us even another ability to be more precise with our surgery and really plan the surgery and execute the surgery in a way that it's extremely targeted and minimally invasive. So this is just these are some examples of patients who have had surgery done with augmented reality, just to give you like a visual idea as to what we can do with these newer technologies. And then the next level is virtual reality and so forth. So it really gets very, very exciting. It really will help us to provide even better care in the future.
Well, maybe we pause for a moment and take some questions relevant to what we've
Sure.
been hearing.
Yes.
First question was, talk a little bit about the successes of minimally invasive surgery in terms of outcomes, and how many may potentially not have a fusion and then eventually have to have a fusion. Maybe share some, stories about that.
Yeah, I mean, I can say, Neel and I, we talked about this earlier. The one thing that minimally invasive surgery has allowed us to do is to avoid fusion surgery. And in my opinion, that's really one of the biggest advantages. It used to be, for example, patients who had a condition called spondylolisthesis in the lumbar spine, where one bone is slipped forward on top of the other. In the old days, when these patients needed surgery because they had lumbar stenosis at that level, they would always get a fusion. And that was because before minimally invasive surgery, in order to treat this, we had to remove so much bone that just by virtue of the operation, the spine became unstable and therefore the patient needed a fusion. Now with minimally invasive surgery, if you do the same operation now with less invasive or minimally invasive surgery, where you take the pressure off through a little tube or through the endoscope, you don't make that spine, you do not render that spine unstable, and therefore you don't have to do a fusion. Now, that doesn't mean that nobody is ever going to have instability, but it significantly decreases the number of patients who really require fusion surgery. And in my opinion, that's really one of the most stunning and really remarkable advances in spinal surgeries that you can really prevent and avoid fusion surgery in so many patients.
I think Roger's correct. He's also being modest because he really authored a really landmark and award-winning paper showing that minimally invasive laminectomies, which is the removal of bone to free up patients who have spinal stenosis, that fusion is not always necessary in that. The minimally invasive techniques really need to be as successful as any other technique. We don't want to do something smaller just because it's small. If it's not effective, we want an operation that is at least as effective and perhaps even more effective for the long run.
Yeah, and there was a question early on about the interspinal spaces. I just wanted to, I'm going through, there are a lot of questions, which is great. The interspinal spacer, it is a device that falls into the category of minimally invasive surgery devices. It's great in certain types of patients, but if it does not really provide the relief in terms of decompression of the spine, then there's still the option of performing a decompression through a tube or with the endoscope, or do a bigger operation. Just in response to the question that was asked early on about interspinal spacer or X-stop.
The X-stop.
X-stop, yeah.
There was a great question about whether this can be the same techniques for lumbar versus cervical versus thoracic area problems. Can you apply all these techniques?
Well, each area of the spine has different approaches that we consider for surgery. The real reason for this is several reasons. One is that different areas of the body, the cervical is in the neck, thoracic is in the middle of the body, so we have concerns about the lungs are there, there's major blood vessels, aorta is there. In the lower spine, we have a little more luxury coming in from the front or the back. So that really the approach needs to be customized depending on the level that's involved and the problem pathology that we're treating. That being said, there are minimally invasive procedures for cervical as well as thoracic, although I think probably the major advances have been in the lumbar spine. But certainly our center, Dr. Härtl, is doing a lot of minimally invasive laminectomy for the cervical spine. We do a disc replacement surgery as well, which is more from the front. so that we really run the full gamut of minimally invasive techniques throughout the entire spine.
Can you comment if, I'm sorry, Roger, go ahead.
No, I just see a message from Jane, and I want to thank her for her kind comment. She had surgery last week, minimally invasive laminectomy.
Great feedback. Somebody commented on if you were to re-herniate after a discectomy, would you use the same approach? And what would that entail?
I think, well, it depends. It really, obviously, every case has to be considered and customized. There is always a risk of having a re-herniation after herniated disc, and that could even be without surgery. Certainly seen many patients who had a herniated disc that did not need surgery. They got over it with physical therapy, maybe an injection, and then had a re-herniation. In cases where someone has had surgery and then have a re-herniation that needs surgery, we do have options. We could do another minimally invasive procedure to remove the herniated disc. I found in my practice doing endoscopy, coming in a little more from the side to avoid some of the scar tissue, has also been a very effective and very minimally invasive way of surgically treating recurrent herniated disc.
Yeah, you want to talk about laser spine surgery? That was a catchphrase for many years, and it still is.
Yeah.
It sounds great. And, we use lasers in surgery all the time for different applications. I think, and Eric, I assume you agree, laser for spine surgery has been used for a tiny little portion of patients who had certain types of disc herniations, and it has been used for those patients. But it has not really allowed us to do anything that we wouldn't be able to do with non-laser surgery. Meaning, there's no advantage inherent to lasers, the lasers that really gives us any benefit in terms of performing minimally invasive spinal surgery. So it's really a catchphrase, and it's being used to attract patients. So as a matter of fact, I think it's actually dangerous.
They actually went bankrupt, so I'm not sure that term is being used anymore.
Yeah.
Okay, there was a question about fusion and whether that can be done in a similar minimally invasive fashion. I think you touched on that, and we can expand on where's the future going with this. One thing I haven't heard from you guys was what your thoughts are on robotic surgery.
Well, I mean, we can go to the next slide. We have a nice picture of a robot. And there we go. So this is the Da Vinci that's being used for certain type of prostate surgeries and lymph node biopsies and so forth. So these types of devices are being used successfully in areas outside spine surgery. For spine surgery, what we use is actually the next. If you go one step further in terms of the slides, this is a robot that is being used now to put in instrumentation or screws into the spine through tiny little incisions, and that works very, very very successful. Again, the precision is greater to insert pedicle screws or instrumentation into the spine with navigation or with a robot than it is without. Studies have shown that. And it allows us to do minimally invasive fusion surgery. So there was a question about minimally invasive fusion surgery. I would say the majority of these fusions now that we do are minimally invasive or are less invasive. And robots and navigation certainly allow us to do this much more successfully and much safer than we used to be able to.
The use of a robot really incorporates the navigation system that we've been talking about. Again, it's kind of like a Google Maps, but then having a self-driving car to follow that. Obviously, the surgeon has to be in control and know where we're going, and that's done by a screen. Often some of the information is planned before the surgery, before the patient even walks into the operating room. And that allows the surgery to be done often in a quicker, more accurate fashion. So certainly the advent of robots is really helping making spine surgery more reliable, successful, and less invasive.
Well, there was a question on what you commented on earlier, Eric, was how fast a person can potentially leave the hospital, return to activities. And then I would add to that one in some of relation to pain relief and pain medications used post-surgery and how the MIS and endoscopy has changed that.
Mm-hmm. You know, a little of it depends on the exact type of surgery. There's no one type of minimally invasive surgery. It really depends on the problem. We have minimally invasive surgery for spinal stenosis, herniated discs, even fusion surgery. In all of those cases, there's a shorter hospital stay, quicker recovery, less pain medication use. Patients are going home routinely within a matter of hours after a herniated disc surgery, a minimally invasive microdiscectomy. I think right now we're sending most of our at least single level laminectomies home. Sometimes patients, depending on their age or other factors, may stay overnight, but it's exceedingly rare for them to stay more than just one night. Even fusion surgery, the vast majority of our patients will stay overnight, but home the next morning. And it's very important they're up and moving and walking. And contrast this with the more traditional open fusion, where patients are in the hospital 3 to 5 nights and are on narcotic medication, often for a period of weeks. Even with a minimally invasive fusion, I do emphasize to patients they may need some narcotic medications for the first few days, because we do want them up and moving and walking, but generally they're off the medication within a matter of days, certainly within 5 to 6 days.
Neel, there's a question about fusion L2 to S1. I just want to comment on that. Yeah, that can be done with minimally invasive surgery. It requires multiple incisions usually. The goal of minimally invasive surgery is, again, to reduce the injury to muscle, to bone, to soft tissues, and then to improve your postoperative recovery. So sometimes instead of making one big incision, we make multiple small incisions, but that allows us to protect the muscle, reduce the infection rate after surgery. L2 to S1 can certainly be done with minimally invasive surgery. It depends a little bit on the circumstances and if you had surgery before, but for the most part, yes, it can be done with less invasive and minimally invasive surgery. There was another question about the nerve. How do we assess the nerve during surgery? I think that's also a very good question. Now, you got to remember, if we go in with a microscope or with the endoscope, we can see the nerve. So once the nerve is decompressed, we can actually see that. In other cases, like the bigger fusion cases, we actually stimulate the nerve. We have probes that we put into the skin and into the spine to stimulate the nerves, so we can make sure that those nerves function normally before and after.
And very often, depending on the surgeries, we will have neuro monitoring, which means we have a team of neurologists, physiologists who are in the room, electrodes connected to the patient. So we really could tell the function of the nerves and during the surgery, even under anesthesia. Why that's important is that gives us immediate feedback about what we are doing, and that knowing that what we're doing is safe, and if we happen to be near a nerve, we know, so that we can be particularly cautious, and that absolutely makes surgery safer.
So how does one, as a patient, and this may be a question that's less relevant here because everybody's already familiar with Weill Cornell, but the term minimally invasive is getting used more commonly. And how do you, as a patient, determine who really is doing something minimally invasive versus is just less invasive than before?
Yeah, I think.
Is there a standard for this?
Yeah, no, that's a great question, because I certainly have seen websites of surgeons, hospital centers that talk about minimally invasive spine surgery, and I know what they do, and they're not doing true minimally invasive surgery the way that we're doing. It sometimes can be hard. I think it's important to, if you're getting a consultation with a surgeon, to ask them what is their experience, what are some of the alternatives in terms of doing things even less invasively, and often getting other opinions at a center that is known and specializes in true minimally invasive surgery?
Yeah, Neel, I think that one part of minimally invasive surgery, and in my opinion, sometimes the most important part is really the diagnosis part. And then obviously then there's the technical part. So the surgeon has to be able technically to perform the surgery in a minimally invasive fashion, and then you need the institution, you need all the equipment, the navigation, the microscope. But really, the first step is the diagnosis. So I think which in a way is reassuring for the patient, because that's where you get to know the surgeon, that's where you get to know the institution. So I think as a patient, it's important to make sure that you get the sense that the surgeon and the team, and that includes also then maybe the spine center or the non-operative physicians, that they really make an honest and thorough attempt to diagnose the underlying problem. Because there's a temptation, if you don't have a good diagnosis, you end up with a huge operation because you don't know exactly what's causing the problem, and then you say, oh, let's treat everything, and that requires a big operation. So if you go to a place where the system is set up in such a way that it's geared towards achieving a good, accurate, targeted diagnosis, that's the first step in really then also continuing on a path to a less invasive operation.
So if we take Linda's question about L4-5 with the concern of arthritis and spinal stenosis there, I mean, I know I can address this question from my viewpoint, but as a surgeon, what would you want to see done before you determine to operate on that area?
Well, a few things. One is speaking with the patient to find out what symptoms they're having. And it's a question I always ask patients is, how is this affecting your activities, your function? If someone tells me, oh, it really doesn't affect my activities and function, then they may not need any treatment, so they may not need surgery. In cases where they do have significant narrowing of the spinal canal, spinal stenosis, symptoms that go along with that kind of picture on the MRI, and very often we will recommend things like physical therapy as a first step, maybe even send the patient to you, Neel, for a epidural steroid injection. Very often they can be effective. It's variable, not in every case, and sometimes it does need to be repeated, but certainly it's a conversation that is important to have with the patient. I would always discuss with patients non-surgical option before surgery if we're dealing with pain. Sometimes that could be very different if there's loss of neurologic function, weakness, but in cases where it's just pain, then pretty much always consider non-surgical treatments, at least as a first step.
Great. I think there was a great question about, does this get covered by insurance the same way that traditional surgery does?
Yeah, it pretty much does. Fortunately, the insurance carriers and Medicare and so forth, they don't ask exactly, in terms of the technical details, what are you doing as a surgeon? So they don't really care if you do an operation open or minimally invasive, so they cover it for the most part. There's sometimes procedures that are more recent, such as Intraspinal Spaces, for example, for a while weren't covered, but now they are. I think endoscopic surgery now has also a reimbursement code. So for the most part, as a patient, you don't have to worry about coverage because these are all covered by insurance.
There was a question about scoliosis and MIS role in treating that. How do you guys approach it?
Certainly at Weill Cornell, we have specialists who work on scoliosis, and really, again, a philosophy of minimally invasive techniques. To treat a scoliosis, if that's really the goal, may require a larger surgery than, let's say, just a microdiscectomy, but still there may be ways of minimizing that surgery, making it smaller. And sometimes, as Dr. Härtl mentioned, we may treat just one aspect. Someone may come in with scoliosis, but also have problems from one particular area. Maybe have a herniated disc, they may have spinal stenosis, and that's causing a problem. And we may decide, and again, after speaking with the patient, to just take a less invasive route and just take care of their stenosis, for instance, with a minimally invasive surgery, and not reconstruct the entire spine to do a deformity type of surgery. So I think that's also something to consider when we're talking about minimally invasive surgery. It's also the choice of surgery and making the right diagnosis.
Yeah, I want to add that, scoliosis, somebody who has significant scoliosis, that is a big problem, and minimally invasive surgery may not really be the answer. I think we got to be very honest. Sometimes patients have scoliosis and maybe they're only symptomatic from one nerve being compressed at one level, and sometimes we can go in there with minimally invasive surgery and fix that. But if somebody really needs the whole scoliosis addressed, and that's something that needs to be very thoroughly evaluated, then you really need to be treated by a trained and an experienced scoliosis surgeon. And we have those. We have those at Weill Cornell. We have those, with Ox Spine. We work now with Ox Spine. So we have a wonderful team of scoliosis surgeons who are perfectly capable of treating scoliosis. But then we're getting away from the topic, which is how small can it get? Then it gets to a big operation. But if well done, then that's the right thing to do, and patients do very well.
Yeah, I think I realize the theme that we're seeing here, which is minimally invasive has really advanced the field, but the biggest thing is the right technique for the right patient, even in these various options that you're talking about. So
Absolutely.
certainly appreciate that. A couple other questions that came up. One was about N-S injections. I'm going to assume nerve blocks or steroid injections, and whether they correct the problem or so forth, or even nerve blockers. It's sort of shifting us away from our topic today. I'll say in a quick fashion that a lot of these injections have therapeutic effect, but as we just finished talking about, a lot of it is used for diagnosis as well to further guide treatment, including surgery. So if you have two levels of problems, and if we think that we could potentially get this addressed with one level, that injection may be helpful in that part.
Often the way I think of it and discuss with patients is that the problem is the pain, the problem is the limitation, and then maybe caused by spinal stenosis or herniated disc. But if we can treat and manage or eliminate someone's pain, then without a surgery, without necessarily correcting the underlying problem, but take care of their pain, then that's really an effective treatment of what's limiting them.
Understanding that obviously it's patient specific, but I know that working with you guys, you've developed protocols on when patients go home, what is the anticipated recovery time, how soon can they return to work and exercise and so forth. Can you share some of those things that you've developed?
We have several protocols. Protocols mean sort of a guideline of how patients are treated through the system. And we really want to be as uniform as possible. The best outcomes are when patients are treated in a very similar, consistent way, and not one patient exactly this way or that way. They may go home in 1 day or 3 days. We want to make sure patients, for instance, have the same medications that we know are successful when they go home. Obviously, everything has to be potentially customized if someone has an allergy, but at least something to start with. One of the protocols we have is called ERAS. ERAS means Enhanced Recovery After Surgery. And that really has been shown to be very effective in terms of keeping patients, getting them out of the hospital quicker, controlling their pain, limiting the amount of narcotic usage as well.
Well, we have about 5 minutes left. It's a great question that just came in about MIS and going through the front versus the back.
Yeah.
Anybody want to take that one?
Sure. I mean, some of the real successful surgeries that we do, we actually do from the front. And that's something that I remember when I was training in spinal surgery, I was surprised to hear that. And but it's really true. And the reason is that there's very little muscle to operate through. What's causing you pain discomfort, disability after surgery, after spine surgery, is injury to the muscles and the soft tissues. And if you think about it, if you operate through the stomach, or not through the stomach, but underneath, through the front, there's very little muscle that really needs to be separated in order to really get to the spine. So patients, if again, for the right reason, in the right patient, if patient needs a spinal fusion, especially in the lower part of the lumbar spine, L5, S1, or L4, L5, an operation where we go in from the front allows us to put in a very, very big cage, which provides more stability, higher fusion rate, and we can even fix the cage in place from the front by putting in screws. So some of these patients just have front surgery, nothing from the back, so you totally avoid the muscle. And these patients actually do really, really well. And sometimes in patients, we talked about scoliosis surgery. Sometimes we do a combination. We go in from the front and from the side and from the back. But again, always with the goal to minimize the amount of injury that we do it to the muscular coverage of the spine.
A couple of questions that are on discussions of pain management techniques like radiofrequency ablation and spinal cord stimulators. In the interest of time, I'm probably going to pass on those questions. We have had some past webinars that you can find on YouTube, specifically talking about those techniques and who's a good candidate for that. Parting thoughts, I don't like to end on a negative note, but we didn't talk about what's the downside MIS, and is there something?
Yeah, I mean, for me, just listening to us talk and looking at the question, it's really a team sport, right? I talked about the diagnosis, how important that is, and that requires a team. That's why we have pain management, neurology, all these people help us evaluate patients to come to a diagnosis. Then in the operating room, you're by yourself as a surgeon, you have an assistant, so you're pretty much on your own. You got to do a good job. And then afterwards, again, it's the team. Eric talked about anesthesia, the ERAS protocol. That has allowed us to be so much more successful as surgeons because patients have less pain, they go home earlier and so forth. So it's really all about the team approach. And I think that's important for patients to understand. If you pick your surgeon, you shouldn't pick a surgeon who operates totally on their own. You really want to go to a place where you have a team that works together before and afterwards. And then the downsides, in my opinion, of minimally invasive surgery is a failure to diagnose the problem. We see patients all the time who come from other places who had sometimes the least invasive surgery I can think of, but they still have the same problem that they had from before because it wasn't diagnosed correctly. So if your diagnosis is off, then your operation is going to be off, and the patient is still going to have the same problem, even though they had a minimally invasive operation. So that's a real problem.
Yeah, I think the way we approach our spine surgery is really a matter of philosophy that we want to do in cases that need surgery as least invasive a surgery as possible. And that goes with the decision of what is causing the problem, again, the diagnosis, treating that problem, and then using some of the cutting edge techniques that we have here, technologies to really get the patient through to treat their pain, improve their activity and their function. And it's really exciting to be able to offer that to patients.
Great. Let's close on how a patient could be set up for an appointment with you for consideration of MIS surgery. What's the process, especially as things are opening back up now from COVID?
We have that last slide with the telephone number. Yeah, I mean, certainly, obviously, you call either the number at the spine center, or you can find our direct office numbers, Dr. Elowitz, myself, on online. And typically, what we will do is we will want to look at some of the medical information, such as MRI scans. What type of problem do you have? What has been done? Because we don't want you to waste your time by seeing us or that we make the wrong decision and then send you to see somebody that you're not really supposed to see. So we got to review a little bit of that information, but then we'll try to get you in as soon as possible. I'm sure, Eric, your office probably works the same.
Yeah, very much. We do want to see some basic information, not just to make sure that the patient's in the right spot. We want to at least review some initial MRI scans. Doesn't always mean that we are going to recommend surgery. Someone may come in and we may decide that surgery may not be the right option, so it may not be at that time. Another advantage that we have to offer are appointments by video visit. We're doing a lot of telemedicine now, so that if someone is not in the New York area, even if they are and don't necessarily want to come into Manhattan, we have the option of doing at least an initial video visit, and I find that patients are very, very satisfied with that as well.
Great. Well, Eric and Roger, it's always a pleasure to join in conversation with you. And I thank our audience for joining us. Once again, this is Spine Time, available to you on YouTube and also website spine-time.org, I believe. And I welcome all to make appointments if you have questions or things that we can help you with. And in a couple of weeks, we will be speaking about neck pain and treatments for that. So hope to see you all there. Thank you and have a good night.
Thank you, Neil. Thanks, Eric.
Thank you.
Good night, everyone.